Good evening. Welcome to iFocus lecture 42. Today we have a very good friend of mine, Dr. Samar, who is the founding medical director of Disha Group of Eye Hospitals, Calcutta, presenting to us on eye banking and corneal preservation techniques. Dr. Basak is an excellent clinician, surgeon, and an academician. He is from RP Center, and then he focuses on cornea and specifically on lamella corneal procedures, eye banking, etc., and heads the cornea division at Disha. Disha is one of the largest eye hospital networks in the eastern part of the India, and it's a very prominent network in India itself. Dr. Basak is extremely passionate about eye banking and corneal surgeries. He has several books and publications to his credit and has one of the largest series on component keratoplasties. His list of awards is overwhelming. Despite using the smallest font that is available in PowerPoint, I couldn't cover all his awards in one slide. That many awards he has. Mainly, he's a very good uh, uh, video filmmaker. You can see so many awards that he has won across the board for his excellent quality documentation and videography. So with that, I would invite Dr. Basak to share his screen and start his presentation.
Thank you, Santosh, for your kind introduction, and thank you, Center for Sight, for this wonderful platform for PG students and maybe for comprehensive ophthalmologists. It is going on for a couple of years, and people are benefited out of it. And I'll be talking on eye banking India and corneal preservation, and briefly I'll be telling about the corneal blindness. So I am sharing my screen. Is it okay now?
Perfect. We can put it on slideshow. Yeah, that's perfect.
Okay. So I'll be talking on corneal blindness little bit and eye banking in India and corneal preservation. I do not have any financial interest. So if you see the recent data, RAP study 6 in 2019, last September it was published, and corneal blindness is 7.4%. And slide is not moving. Then this study was published long time back, and there it was also said that it is a major cause of blindness, second only to cataract surgery, cataract. So if you see the major causes in India, first one is infectious keratitis, second one is pseudophakic bullous keratopathy or corneal edema, then hereditary dystrophies and corneal ectasia, corneal injuries, open globe, chemical or thermal. The last three, like trachoma, vitamin A deficiency, and miscellaneous, these are now rare. So infective keratitis in India, this was published about 25 years back. Still, we see a lot of cases every day. And you know that in India, 1.31 million ulcer happened every year. Pseudophakic bullous keratopathy, PBK, or corneal edema, exact data not available, but the incidence is 0.1 to 0.5%. And if you see, if we take 0.2, last year we did 6.5 million cataract surgery. So every year we are adding around 13,000 PBK. Then we have granular, macular, lattice, Fuchs dystrophy, and other dystrophies. These are relatively less common in India, but Fuchs dystrophy contributes 15 to 20% of all transplants. In Bengal, it is higher than other states. We have published our data. And then ectasia. Ectasia, because of refractive surgery, because of a lot of machines, lot of topography, tomography, there are more detection of keratoconus, keratoglobus, post-LASIK ectasia, etc. And keratoconus is actually a problem for India. The prevalence, world prevalence is 50 to 130 per 100,000 population. And in India, the prevalence is 2,300 per 100,000 population. And this study was published by Central India Eye Study from Binay Nangian group. Then every day we get such cases of open globe and chemical injury, especially the alkali injury. People are not interested, especially the younger colleagues, they are not interested to learn good suturing because everything is sutureless nowadays. But for that, there is delayed in intervention leads to permanent visual loss. So this is one of the area the younger generation should focus, that it is an emergency procedure. There should not be any complacence attitude towards treating these younger, especially younger children. Then trachoma in our time, trachoma was like 3%. Then there was no active trachoma. But again, RAP study, this is probably RAP4 study, that trachoma is again increasing, especially in Uttarakhand and Rajasthan. So these eye-seeking flies, Mosca sorbens, are responsible for spreading trachoma infection from one to other. Then vitamin A deficiency, it is not an issue nowadays. For last 10, 15 years, we do not see many cases. And because of mass immunization and vitamin A oil is given every primary healthcare center. Cluster problem is still there. We see occasionally few cases in a year. So prevention is the key to reduce corneal blindness, that we know, but solution of happen corneal blindness is keratoplasty. This stamp is, Santosh was asking about philately. This is stamp on keratoplasty and this is stamp on organ donation and eye donation. Beautiful stamp. So we have PK, we have DALC, we have DISEC and DIMEC. We have anterolamellar, other anterolamellar keratoplasty, keratoprosthesis. We have therapeutic keratoplasty. Actually, therapeutic keratoplasty is the majority of the keratoplasty done in India. Overall percentage is highest in India. So if you see the global data, this data was published in 2016. 284,000 cornea procured from 82 countries, 185,000 transplanted done in 116 countries, an estimated 12.7 million people are waiting for corneal transplantation. That means only covering 1 in 70 worldwide. 55% of all cornea procured in United States and in India, and 53% of world population had no access to corneal transplantation. And if you see the religion-wise, Christianity is the highest, 77%, and then followed by Hinduism. So we have in India, majority are Hindu, so we get a lot of cornea. So if you see the corneal transplants in India, the corneal blindness is 1.2 million, bilateral is around 60%, but only 8 to 10% of all corneal blindness will be benefited by corneal transplantation. There is an estimate by Vision 2020 that we need to perform 100,000 transplant every year by 2020. And 2020, you know, everything is shattered. That means this 100,000 transplants, we need actually 200,000 cornea with 50% utilization rate. New patient every year is around more than 50,000. Till last March, every year we used to do 35 to 40,000 keratoplasty in India. This is Eye Bank Association data in last 23 years till 2018. Eye banks and eye donation center has increased tremendously, and total collection of 700,000 plus cornea collected and utilization close to 300,000. Average utilization till 18 was like 39%, but in 19 till March 20, the utilization rates actually increased to 45 to 48%. There is a threefold increase in corneal transplantation in the last 10 years. So this is a very beautiful graph map. From this map, you can see that India is probably the country where we have the highest number of corneal blindness, and we have an opportunity to do highest number of corneal transplantation if we have enough and robust eye banking system. In fact, we are growing tremendously for last 10 years. So for solution 1, that is for keratoplasty, we need solution 2, that is quality eye banking, the talk of the day. So, but you must know that first keratoplasty was done from a cornea from a living donor, not from an eye bank. So first successful human keratoplasty was done by Edward Germ about 115 years back, and three odd things happens that day. First patient who had bilateral lime burn, that is a poor indication for keratoplasty. First donor, 11 years old boy, bilateral bad injuries with good cornea, living donor. And the transplant happened bilaterally. Fortunately, this patient had good left eye and no microscope, nothing was there in that era, and he returned to work. This was the first successful keratoplasty. Then this gentleman from Russia, Vladimir Filatov, in 1915, he first proposed that the use of cadaveric donor cornea for keratoplasty. And he proposed the method of moist chamber at 4 degrees Celsius. He is actually considered as father of eye banking. In 1944, Townley Patton established the first eye bank officially in US called Eye Bank for Sight Restoration in New York City. And in India, 1945, Dr. Muthaiya started first eye bank in Madras Medical College. Now it is RIO Chennai. So Indian eye banking, different model coexist. Institutional eye bank, standalone eye bank training centers, then community eye bank, and many eye donation centers. And they are linked actually with eye bank or training center. Many of them are working fine in terms of efficiency and growth. Some of them are not. Issues like efficiency and sustainability. Many eye banks are just dying itself because of they do not have efficient system. Typically, the government eye banks are not efficient in most of the cases, but except RIOs and All India Institute of Medical Sciences, they are having robust eye banking. So we have three-tier eye banking system in India. We call it eye donation system, eye donation center, which only collects donor cornea. And they transport that cornea to either to the eye bank or eye bank training center. Eye bank is actually, they also collect, they evaluate, they store and utilize. An eye bank training center Above all, they also do the training, teaching, and research activity. Regulatory bodies are NPCB, VI, and iBank Association of India. There are many NGOs and INGOs are helping in Indian iBanking system. So, typical function of iBank: collection, then process and storage, then distribution and utilization. As I said earlier, research and training. We should also promote the awareness about iBanking among the community, and also promote hospital corneal retrieval program. So the series of events happen when a call comes to the iBank. So first there is a call in an iBank, then we must note the contacts, address, etc. Then reaching there, we have to take consent. This consent should be signed by next of kin. 2 witnesses should be there. Then we must have death certificate in hand. Then donor medical review. If you have the papers of treating the patient for first few months or few weeks, few days, review of the donor medical history, then physical inspection of the donor, if any other things are there or not, then go for retrieval. Typically, retrieval is done under aseptic condition. Retrieval can be done by any iBank technician or any RMP, registered medical practitioner, even by nurses who have training. Then after retrieval, it comes to the iBank, and there evaluation has been done. Then after evaluation, there is suitability, to check the suitability of that particular tissues pair. Then after that, it has to be stored in different thing. We will be continuing, we will be coming next part of this lecture. Then release of tissue and transport to same city or transport to other city. When the tissue has been utilized, then we have to check the follow-up of that for few weeks, some adverse reaction happened or not. So this is one particular tissue, series of events happen. And the structure of the iBank is board of directors, then iBank manager, iBank technician, iDonation counselor, data entry operator, and iBank coordinator. This is, and one side is medical director and backup medical director. They give the actually the medical aspect of the suitability of donor or not. They give advice to the iBank. But the iBank manager actually plays the pivotal role to run all this employee of the iBank, and thereby there will be smooth functioning of the iBank. So in India, you see that iBank training center close to 10, then iBanks are 225, 227, iDonation center, as I said, it is plenty. But we have accumulated data that number of active iBank or EDC collects more than 50 eyes per year is around 250. iBanks collect more than 1,000 eyes around 18, 19. This was just before pandemic. So every year there is a number of iBanks or iDonation center addition, and government give permission, but the utilization rate varies between 2% to 81%. So this is a huge gap in iBanking system in India because of proper methodology is not placed in every iBank in the country. Source of iDonation is the voluntary donation. You know that it is just social responsibility, and a lot of people, celebrity, they have helped us to campaign and pledge for iDonation. And prior pledge for eye donation after death is plenty. So we have seen that without voluntary donation without prior pledge is around 99%, and 1% is actually happened after prior pledge. So people actually forget to last moment, the relative actually forget and tell the eye bank about the last wish of that. They actually forget. But some people without prior pledge, they voluntarily call the eye banks and they actually do the voluntary donation mostly. Now the ACRP, it is the big and new and big way it is actually changed the eye banking scenario in India. There is nothing like presumed consent law in India. Like in USA, every driver who has got their license, they have last line is that they are actually compelled to donate their eyes if there is happen. So, and you need not take permission from the relative. It is called presumed consent law. It is not there in India. We have required request law. That means you can request at the time of death to the family members of the deceased about the consent of eye donation. Some people might agree, some people might not. ACRP actually is the growing concept. It is called Hospital Cornea Retrieval Program. The key is the direct motivation of the family member of the deceased actively by professionally trained counselor called eye donation counselor in a hospital setting where the death rate is high. They approach the family members in the hospital immediately after death of the family's loved one and brief them about eye donation and then request for giving consent for donation. So actually this eye donation counselor, they are sitting in a hospital setting. So it is actually going in a long way for last actually 20 years. But for last 10 years, the momentum has picked up because of help of Orbis and SightLife USA. And later on, Government of India actively participated in this ACRP program. So ACRP typical model is NGO eye bank with the government eye hospital. This is called typical PPP model. Government eye bank in government hospital, NGO eye bank in NGO hospital, and government eye bank in NGO hospital. So there are different permutation and combination, but eye bank as a principle should not be a private. It is a NGO wing of a private hospital. They operate on no loss, no profit basis. And for any model, the remuneration of eye donation counselor is always from the eye bank. So there is a huge cost involved in this ACRP model. And other expenses like retrieve and etc. is also borne by the eye bank. As I said that it is typically the public-private partnership model is the best one, and with the help and support of all level of staffs, and consent rate varies between 5 to 60%. And as I said, the center and state government, all actually there are more than 100 similar kind of model in the country. The advantages of ACRP is that death, cornea or eyeball retrieval time is always less. Medical record accessibility is easy and you get the file. History from treating physician is always helpful. History from relative is also important. If required, they are surrounding, they are there. Blood sample collection is much easier, which is difficult in a home setup. And procurement of more younger tissue, because you can choose actually which patient who died you will approach. you will get the proper death certificate in time. And when you are doing this job, a lot of people are watching your activity and better spread of eye donation message. The hospital is typically, as I said, it is a multi-speciality hospital, large hospital where 500 plus bed, having ICU, ITU facility, emergency medicine service is there, centralized death notification system is there, and there should be a direct access to an eye bank round the clock with this hospital. And the death rate of this hospital 5 per day, or at least 10 to 15 per week. So if you choose this kind of hospital, then your ACRP program will be successful. Then the concept of whole globe versus in situ sclerocorneal button collection. Initially, when we started with the whole globe, it is not much acceptable to the family member. But when we switch to the sclerocorneal button, that is in situ collection, it was highly acceptable. And we always, the technician or they initially used to keep glycerin preserved corneoscleral button in a sealed vial. They used to show the family member that we will collect this part from the eye, so there will be no disfigurement, nothing will be there. And they also tell that we'll take little blood for testing of suitability. So the slogan actually not donate eyes after death, donate cornea after death. So that way the acceptability among the relatives of the deceased is high. We have compared some data. We have seen that the ACRP, the quality of tissue is much better. There are several papers on it. Excellent and very good cornea are better than the voluntary collection. And also we have seen that NSFS, not suitable for surgery, is also less in ACRP. Seropositivity are actually same. So I am giving you a small example of our ACRP. This was considered a model ACRP initially. Now many people have joined in this program, a paradigm shift. And there is, when there is ACRP, as I said, there is also increase in voluntary. So we started in 2004-5 junction, and initially our collection was only voluntary. You see the collection we started since the inception of the hospital, 1997. Then this is still 17, but till 20 it has start actually it has actually reached 2000 figure. So you see there is a jump and the curve is going like anything. So total collection versus utilization has increased from since 2004 to March 2020. And also similarly, the voluntary collection and utilization is also because of better message, better this thing. So collection and utilization also increased. So actually every year we collect more than 1200 to 1400 eyes from ACRP collection. And utilization, as I said, it is more than 70%. So concentrate, our initial concentrate was 7.8, and 2017 it was 40%. So concentrate also increased. Our stop pattern has also increased. Initially we started with 4 stops, and later on it has increased up to, now it is 13 stop member. They are doing the work for eye banking. So for last say 15 years, we have collected more than 13,000, 14,000 cornea from ACRP collection only. So the first rise happened when we shifted to CS button. As I said, the acceptability is higher. And second side, we have a professional approach from we are trained by Sightlight people, and they had helped us to grow. And you see that first 5 years it was 339, and last 5 years it was close to 10,000. And utilization, our utilization is always highest in the country, around 75 to 80%. And transplant is also, see that 100 plus we reached in 5 years, 1,000 in 10 years. The next 10 years, we actually have done more than 10,000 keratoplasty. So efficient HCRP means maximum utilization, more revenue for the eye bank. It is a self-sustainable model, and there is always a scope for growth. So record of some timing are important for like time of death. This is in any eye collection, time of death is important. Death to whole eyeball retrieval time, it is a whole eyeball. Death to cornea retrieval time, it is a sclerocorneal button. But when you are here in cornea retrieval, CS button retrieval, you are directly putting it in preservation time. So you do not have any cornea preservation time. Whereas whole eyeball retrieval time, you have to take the eyeball, then they treat the eyeball, then you have to prepare the sclerocorneal button. It takes time. So there you have three time of death, whole eyeball retrieval time, and cornea preservation time. But in case of corneoscleral retrieval, you have time of death and corneal retrieval come preservation time. Usually the eye is collected within 4 to 6 hours of death. Summer months it is 4 hours, winter months it is 6 hours. 4 to 6 hours is a very nice time. And usually by Government of India rule that death certificate should be issued after 1 hour after death, not 4 hours. Many people say that it is 4 hours. No, Government of India has notification, it is 1 hour after death. But from a mortuary, you may take even after 12 hours of death, depending upon the type of mortuary it has been preserved. There are contraindications for collection. So you know that these contraindications are very important for eye banking. One is extreme of ages, but we collect all eyes irrespective of age. But many eye banks, they have limit. No, you have crossed 80, so we have not, like in Maharashtra, this rule is there in some of the eye bank. If somebody has died at 90 years old, the eye bank said, no, we do not collect above 80 years of age. Similarly, but this is depend upon the eye banks to eye bank. But if you see that main important thing is death of unknown cause, there's all yellows are actually, you should not collect. CZD, rabies, hepatitis B, C, HIV-1, HIV, TLV-1, 2, HIV, and syphilis. These are all actually absolute contraindication. There are some other contraindication like relative contraindication, active viral encephalitis of unknown origin, SSP, any form of leukemia, active disseminated lymphomas, active septicemia where we have several logic is there, retinoblastoma or tumor of the anterior segment of the eye, aptic ocular infection such as exposure keratitis or corneal ulcer, because many patients are in coma, so there is exposure keratitis or ulcer already, frank ulcer is there, so you cannot collect those eyes. And if there is behavioral or social issues like drug addict, homosexualism, etc., etc., etc. So these are in brief the contraindication. There are pages and pages you can read from the text. And now the one of the absolute contraindication is COVID-19. So we have guidelines about collection and procedures by the AIOS, EBAI, NPCB, all are same basically. You could read those things that we are actually, we have started the iBanking scenario in the current situation, there are some do's and don'ts are there. So this is one of the contraindication which has been added recently. Then after getting the tissue in the eye bank, you have to go for torchlight examination, then slit lamp evaluation, serology testing. As I said, that 5 millimeter blood sample collected from all donor from the jugular vein mainly for HIV, Hep B, Hep C, and syphilis serology testing. So once you do the serology testing, if it is negative, and then you could go for CS button preparation. If it is a whole globe, you have to use under sterile environment in a laminar flow hood system with sterile instrument, and you need training for CS button preparation. Then we have to go for specular microscopy to see the corneal endothelial cell counts of this donor tissue. Then microbiology, many eye banks follow, many eye banks do not, but it is optional, but we feel that it is always helpful. Slit lamp, their predefined guidelines are there from epithelium to endothelium. You have to check. Adequate thawing is very important to take the tissue in the room temperature condition. Then you have to examine under slit lamp. Different for whole globe and CS button. For whole globe, it is wise to take in a moist chamber, maintain sterility. If there is any hypotony, give little pressure so you could see the corneal structure very nicely. Dry epithelium, you need to put some antibiotic drop. Temporary folds are there, so you have to identify and differentiate between temporary folds and permanent fold. For CS version, there is a holder system via a mirror, give the accurate picture you need to see under regular. From endothelial side, we usually see, but you have to turn the CS button so that you could also examine from the epithelial side. So specular is also very important. Today's era, unless you get a picture like this, you are not sure about the cornea. Though again, the adequate thawing is important in the room temperature, based in viewing chamber. And newer eye bank specular microscope gives a beautiful picture, like 4-field picture, and you can see nice endothelium, more than 2,700 count per square millimeter. This is wonderful. People will love to, the corneal surgeon will love to use this cornea for, especially for endothelial keratoplasty. Then you have to have multiple reading, average of 5 or 3. Technician can do it. And minimum cell count, you need to do 100 cells so that you get a more accurate number of cells and always get a printout. Now, my next part is cornea storage and preservation. You see that if you classify it, it could be classified as short-term storage, intermediate-term storage, and long-term storage. Short-term storage is like less than 4 days or 96 hours, moist chamber and McCarey-Kaufman, MK medium, and intermediate oxytosol GS, cortisol, Life4 C, Usol C, Kesol, Dextrol, chain medium. These are less frequently used. Then we have long-term media lies more than 30 days, organ culture media. Then we have extra long like glycerin preserve and cryopreservation. These are basic storage media. So moist chamber, we know that many eye banks still use this, EDC especially use this as a cornea preservation method. Freshly enucleated cadaver saline soak gauze for humidification in the lower part, and instilled antibiotic drops a holder for stability, and storage at 4 degrees Celsius between 2 to plus 4 degrees. And 24 hours is the usual, but you can keep up to 48 hours if the condition is much better. Then we have moist chamber, like it is simple and inexpensive. Still a popular transport media, as I said, from in India, from eye donation center to eye bank. But disadvantage is endothelium is constantly exposed, is aqueous wear, I mean bad aqueous, and limited duration, and you need to use it urgently in the same day, same night, and there is no metabolic supplement for this endothelium, and rim excision you always, and then you have to transfer to liquid storage media, and from it you can do anterior stiffenation, or if you prepare rim, you can do posterior stiffenation from endothelial side. From whole globe to endothelial preservation, Stocker in 1953 first proposed endothelial preservation, and then this tissue culture medium concept come TC199. It is then later on supplemented with chondroitin sulfate, ATP precursor, and antibiotic. So the concept actually late 60s or early 70s. But then in 1974, McCurry and Kaufman, they come with this media, cornea scleral button, plus 2 to 8 degree, up to 96 hours. This is the most common liquid media in India, now produced in LV Prasad and also RP Center, and some of the eye bank, they also use same. Cost is around 500 and plus GST. So cost is also important for eye banking, because this eye bank doesn't have other income, so you have to think about this. So it contains TC199, 5% extant, 40 Hepase buffer, penicillin and streptomycin as antibiotic, and phenol red as pH indicator. So if there is any color change, you have to discard even after that, before preservation and after. So that's why this color is very important, because contamination with microbes is not so uncommon with liquid preservation media. In late 80s, the chondroitin sulfate, then K-salt, Dexot, and other micronutrient actually added, and increased the storage duration from 7 to 10 days. McCurry-Kaufman was actually for 96 hours. Then it was aimed for storage up to 14 days. Optisol was introduced in 1990s, hybrid of K-sol and Dexol. So the question is, what is the natural source of, we'll discuss during discussion, natural source of chondroitin sulfate. So Optisol GS media, most popular intermediate worldwide, Optisol GS. And you see that it is again, the preservation is same, plus 2 to 8, up to 14 days of storage. Cost is around $50 plus shipping. It is usually imported from USA, 20 ml vial. And this is actually a viewing chamber. So it is a nice chamber where the corneal button, it doesn't move much. So the endothelium gets less damaged when you ship in a bottle versus you ship in a viewing chamber. The composition wise, again, TC19, minimum essential medium, balanced salt solution. As I said, chondroitin sulfate, 1% dextran, ATP precursor, Hepase, micronutrients, gentamicin and streptomycin. That GS stand for gentamicin and streptomycin, and again phenol red as pH indicator. Then usual C media, it is also popular in some European country, And here the pyruvate and glucose as energy source, dextran, gentamicin, phenol red as indicator, and storage up to 14 days. Entirely it is a synthetic unused vial. I mean, normally this vial is usually stored in a refrigerator when it is not used. So the only advantage is that unused vial can be stored in room temperature. This is usual C. Then Life Force C media. Life Force C, we have used some donated by this company, but later on, because of cost, we cannot afford it. It is the Optisol GS plus refinement, like recombinant human insulin, reduced glutathione as an antioxidant, membrane stabilizer, and micronutrients. It helps to keep the keratocyte better and longer epithelial cell survival, greater tissue detergence. So you see the tissue will be much compact in Life Force C, and 30 ml. This they consider 30 ml transport cum viewing chamber. They come as a combination of these two. Again, 2 to 8 degrees Celsius up to 14. The cost is around 5,000, whereas Optisol GS is around 1,800 to 2,000. Then our own cortisol media. This is the Optisol GS plus refinement. It is actually made by Orolab, recombinant human insulin again, and membrane stabilizer and micronutrients up to 14 days. It is affordable at a cost price of, including all cost, it is around 1,300. It is compared to Optisol, and data has been published. And the first data published in Cornea Journal in 2016. Then organ culture, actually for long-term storage up to 30 days, popular in Europe, technically demanding, and allows longer quarantine period, and it requires, they had a like prion disease test, mad cow disease for media with bovine serum. And so actually this is only popular in Europe, but this is very costly and very, very cumbersome. Only advantage is you can keep in the room temperature. Then very long term storage, like these are all non-viable storage, actually reserved for non-optical grade tissue for an emergency use when tissue is not available, like this situation of pandemic. So common methods are glycerol preservation, lyophilized cornea, gamma irradiated sterile cornea, and cryopreservation. These are the four common, but only we use this glycerol preservation in India. Other are actually in many places in USA there, but cryopreservation was not popularized. Glycerin preservation, easy to implement, stored in 95% glycerin in a seal vial. It can be kept at room temperature for years, 1, 2, 3 years, and you can reuse it for tectonic support. Gamma irradiation is actually to irradiate the cornea and to decellularize it, and it also kills any microorganism. It is useful in anterior-lamellar keratoplasty and keratoprosthesis carrier, tectonic, and some cases of small therapeutic purposes. Cryopreservation actually stored at -196 degrees Celsius, and cryoprotectant actually added to prevent damage, cell damage by ice crystal, rarely used nowadays and need complexity and huge costly. Lyophilized cornea and or freeze-dried cornea, again decellularized cornea. This is maybe cryopreserved, and this is also maybe used for tectonic purpose and ALK. So the special mention, few slides are there. Special mention are like corneal preservation in COVID-19 time, renewed interest in long-term preservation for two reasons. The patient's footfall is also unpredictable, and tissue retrieval is not going as per March 2020. So we have to use this tissue judiciously and have to keep as a backup tissue for emergency purpose. Current concern and future direction will be like endothelial preservation with stromal detergation and with This is the current corneal preservation technique: endothelial preservation, stromal detergation with antibiotic cover. But more focus is needed regarding epithelial and limbal cell preservation. And there is increasing report of fungal endophthalmitis with the pre-cut tissue, maybe due to repeated warm-cool cycle. Normally we allow only maybe 2, but in US, because of shipping multiple places, there is many more warm-cool cycle. So there are addition of antifungal to the media like Ampho-B or Caspofungin. And like shifting older antibiotics, streptopenicillin to Moxi or other 4th generation fluoroquinolone. The cost of storage media, already I have covered this. So grading and distribution of the tissue, like excellent, very good, good, fair, not suitable for surgery. Excellent is more than 2,500 cell count, so it can be used PK, EK, DSEC or DMEC. Very good, 2,000 to 2,500 PK and some cases of EK. Good, 1,500 to 2,000 PK or therapeutic PK. Fair, less than 1,500, it is DAL, therapeutic PK, Tectonic or Kpro. So these are the simple grading system, and after doing slit lamp examination and specular count. Record keeping also important part of eye banking. Data is important for every aspect of eye banking, starting from donor information, recipient information, data, serology data, day-to-day performance, ECD, EDC, eye donation counselors, concentrate, utilization data, type of keratoplasty, etc. These data are actually confidential only with the eye bank. There are some basic ethics of eye banking. We should all know this. Eye tissue or cornea cannot be bought or sold. Distribution of tissue irrespective of race, creed, religion, etc. Distribution as per predefined priority, as per waiting list, and as first come first basis. So there is a predefined priority list by the eye bank and Government of India. Donor information cannot be shared with the recipient. This is very important. Donor information cannot be shared with the recipient or any other person. Donor and recipient identity cannot be disclosed to any except for legal reason or for government grant, etc. There should not be any competition between two eye banks. These are few basic ethics of eye banking. So this is our final goal of 3-tier eye banking, that one eye bank per 20 million population. This was calculated long time back actually. So we had calculated 5 eye bank training center, 45, total 50. They will collect around 4,000 cornea per eye bank. So there will be 200,000 cornea per year. And for eye bank, there will be like 40 eye donation center, and each eye donation center actually contribute to 50 cornea. So, and 10 ACRP center per eye bank. So it is India, our death is more than 10 million. We have calculated if the consent rate is just 1%, we can actually cover our need of 100,000. So this was the verdict in 2020, but 200,000 cornea, 100,000 utilization, but by the year 2020, 1,000 corneal surgeon, and each surgeon will be transplanted 100 transplant per year. So I have put a big question mark. Because of pandemic situation, we are back by maybe 7-8 years. So, but still it is highly possible. If we have a proper spirit and proper goal, it may be possible by 2025. So we'll hope that lot of things we learn from this COVID-19 and pandemic, and also in the iBanking, organ transplantation. Thank you very much for your patient hearing.
Thank you so much, sir. You have covered it in very detailedly. So we have few questions from different platforms. May I take the questions now?
May I just slide share off? Yeah.
Okay. So the first question is, can we retrieve a cornea from a patient who has already undergone keratoplasty, and can it be reused again?
Yes, we can retrieve the tissue. We may not use the cornea, but other parts of the cornea, like limbal cells, if the limbal stem cells is good, we can use that. We can use the sclera also. So normally we do keratoplasty in the central 8 millimeter zone. So that part, but we can use the, like, say, if we get a cornea like that, we have a scleral patch graft, we can use that eyeball. That in that case, we have to collect the whole eyeball, not only the sclerocorneal button.
Okay. The next question is, what is the time when we can do keratoplasty in patients with chemical burns? Is it that after the inflammation subsides immediately
Yes,
can we
yes,
do
you
it?
have to actually, keratoplasty in chemical burn, normally we wait. Normally that limbal cells, LSCD or limbal stem cell deficient, what has happened, the amount of LSCD is important, vascularization important. Probably the patients need some form of treatment like slit surgery before that, before doing keratoplasty. Normally we do not directly go to keratoplasty in a case of chemical injury, except that it is central, every limbus is fine, we can do that. But normally we have to address the limbal cell deficiency in these cases first, then we'll have to go for either PK or DALK, sometimes deeper tissue are fine, so we can go for it. Or maybe keratoprosthesis, some cases where you cannot do even PK or DALK.
Okay. The next question is Parkinson disease a contraindication for eye donation?
Relative contraindication, yes. There is a concept that Parkinsonism and Parkinson-like diseases, because people are considering that it is a slow viral disease. This is one side of the story. Another side of the story, lot of Parkinsonism patients, they get amantadine tablet for a long time. And amantadine tablet actually causes problem with endothelial cells. So you may not have very good endothelial cells. You may have good morphology anatomically, but uh, functionally, this endothelial cell may not be good. So that is why that for two reasons, Parkinsonism is a relative contraindication.
Okay. So can we do eye retrieval in patients who are intubated, or is it a contraindication?
Intubated, yes, why not? Intubated means only you have to see that patient is a septicemia is there, and there is a long list of debate. We have always have a debate, septicemia. Do we use that? Intubated? Yes, we can use it. For what
Okay.
reason intubated? All these things will come.
Okay. The next question is, if we use moxifloxacin or any fourth generation fluoroquinolones in preservating the corneas, so after the transplant, does it not lead to more resistance?
No, we do not know actually. We do not know. These are thoughts for future because of that gentamicin and streptomycin, they are out of the world nowadays. People do not use it mostly. So IBank people still manage to get it. So there are experimental studies are going on with Moxie actually. Moxie one hand and other hand, they're still not commercially available. People will come up with the data that what is wrong or what is right. But that way resistance will not be, probably not, because it is a so minute amount, probably not.
Okay. So the next question is, can we retrieve the cornea if death certificate is not available?
I cannot get your question.
They have asked a question, can we retrieve the cornea before the death certificate is issued to the patient?
No. Big no.
Okay. So the extension of the
You
previous
have the
question.
death certificate in your hand, then you will proceed. Big medical legal problem, whatever the thing is there, unless you get death certificate, you should not proceed.
Okay. The same question they asked about the antibiotics as a preservative. Is that, does the same thing apply to the antifungals also?
Antifungal, they are all experimental because they have a few cases of fungal endophthalmitis or fungal interface infection happened after EK, especially with DSEC or DMEC. So they are concerned that probably there is contamination happening. Commensal, normal commensal is there in conjunctival sac, probably it is lying there. So mostly they are candida. That's why they are giving actually amphotericin B.
Okay. In a few cases, in cases of home deaths, when there is no death certificate, in such cases, can we go ahead with the eye retrieval?
This is important question. Like those who are a little away in a suburb situation, you may not get. That's why for home collection, if a MBBS doctor or anybody accompanied the technician, he can actually issue the death certificate. Do you understand my point? So
Yes.
I have done that many times. When I used to go, there was no technician concept that time. So I used to go, and it is like a little remote. They do not get at night. Nobody is there around to give death certificate, or you have to wait till in the morning. So I requested the family, can I give the death certificate? He said, yes, you can give. So I see all the signs of death and write death certificate. So that's why the RMP means MBBS, homeopathy, all the Unani, all group will come together according to Government of India definition. They can issue death certificate. So that way you can actually go and you can write the death certificate and your technician collects, or you collect yourself also. There is no problem.
Okay. So that's all for the questions, sir. Rest of the questions you have covered it in your talk. Any hot seat participants, if you have any questions, you can ask.
No, I asked one question. Na? What is the natural source of chondroitin sulfate? Anybody could answer it.
Ajiba can take the question.
Sir, of bone marrow.
Cartilage.
Natural source, where the company will get.
Sir, sorry, sir.
From where the company gets chondroitin sulfate. Like Viscoat you use in cataract surgery, it contains CDS. And all the preservative media, they also contain CDS. From where this CDS comes from?
I'm not sure, sir.
What is the natural source? So there are artificial sources also.
Cartilage. No?
So
Ligament.
It is actually from shark's fin. Shark's fin. You know that 3 years back there was a big problem of in the commercial market. CDS was very difficult to get because of there is the most precious source area is Japan, that Fukushima island where that nuclear some happened near that. The shark in that area, the shark fin is the richest source of chondroitin. I mean, top grade chondroitin sulfate. But because of that plant, something happened, nuclear plant, some power plant, some damage happened. So they cordon that area for say 100 kilometers. So that time the shark, they could not retrieve that. That time there was a crisis of CDS in the world. I mean, number one CDS. There are, of course, there is always a number two CDS, but shark fin is the source of chondroitin sulfate. Like sodium hyaluronate is coxcomb is the natural source. You have always nowadays artificial source, but coxcomb is the natural source of sodium hyaluronate. Similarly, chondroitin sulfate. Those are very too important for cataract surgeon also. So shark's fin.
Okay, sir.
Sir, if the patient was intubated like for more than 72 hours, is that time limit a contraindication, sir, or any duration of intubation is fine?
Intubation, no, we have not thought of 72 hours. The other sign, intubation per se is not important. Important is that then you have to go back, is there any sign of sepsis is there or not? Or intubation means patient might be most likely in comatose, and you have to check about the eye structure, torchlight examination. Sometimes we see that lot of exposure keratitis in these eyes. So if that sepsis is there and you have all the blood report, that is the best part of ACRP retrieval. You can see the blood report and you think that if there is leukocytosis, etc., and other in favor of septicemia, you should not take that eyes.
Thank you, sir.
Okay, so we have one more question. How can a person register for eye donation before death? And after his death, if the immediate kin doesn't consent for the donation, does the
So
person's
that is
consent
the
is valid?
problem. So we do not encourage people for pledge for eye donation. Maximum school, college goers, they are come and bunch of pledge card is there. We have all destroyed it. So where they will be at 60, 65, 70 or 80 years age. So we do not encourage. We encourage the older people who place their card, and we used to give a certificate, big certificate against that pledge. We tell that you place that in your drawing room because you will not be there at that time. That your family member will remember, somebody will point out, see, that man has placed, if you place it in the drawing room. So that way it might be successful, otherwise it is not.
It only creates awareness, I think.
Awareness. Unless you give a big certificate in the drawing room, they feel हम आंख डोनेट करके आया. हम तो वही बताते हैं, अरे आंख डोनेट कहाँ से होगा, आंख तो कहाँ आप करेगा, आपको बेटा और बेटी करेगा, आप कैसे करेगा. So that is the problem.
Okay, sir. So one more question. If the donor was on blood thinners before death, and if he bleeds when we are taking the sample, so then what should we do?
There sometimes we face problem. These are, you have to be very clever and tactfully you have to, because even the during collection of, if there is whole globe correction, I have faced, and also our technician has placed during iris trauma, little bit, lot of profuse bleeding. They used to console the family member. Then you have to head and elevated actually. From jugular vein, they never experienced this kind of bleeding, but they have experienced during in situ collection or whole globe, mostly whole globe. So head end must be raised and let the blood, and you have to ask for some, if it is hospital, some gauze piece, cotton, etc. And so normally they usually understand. Never we had problem. But this is a problem. But you have to manage the situation nicely.
So the other way around, in few cases, we cannot retrieve, we cannot draw the blood.
No, unless you draw the blood, jugular vein is the first place, then femoral, but for femoral vein you cannot approach unless it is HCRP. From home death you cannot approach for obvious reason, femoral vein. Then direct cardiac puncture is also there. That you can do. If you get 2 ml, that will also. If you cannot draw at all blood, you use the tissue for training purpose. Training, teaching. Don't use that for any therapeutic purpose.
Okay. Thank you so
blood,
much.
No use for recipient.
Okay. Thank you so much, sir.
Now we have published our data in IGO only, that seropositivity in blood, and we in 5 years data, and it is almost 4.2% seropositivity. It is about 5,000 donor tissue, 4%, 4.2%. That is huge figure, no? So 5,000, 4.2% is huge. So you have to be very careful.
Any other questions? Thank you so much, sir. The topic was covered very extensively.
Yeah, thank you so much. Wonderful, very interesting talk, very nice one.
More than 1 hour.
Thank you so much.
60 minutes.
Yeah, this will stay on YouTube and people will continue to access it all through, right? And for next week, we have Professor Tityal speaking to us on penetrating keratoplasty. That's a very interesting and important topic, and I wish all of you will attend. Thank you so much. Good night. Good night, Dada.
Thank you.
Thank you, sir.
Thank
Good night.
you, sir.